Hi everyone. Today we will learn about the summary stage that was developed by Sear. Sear summary stage or summary stage is one of two different staging systems that you will learn this semester. Staging is a shorthand method of describing disease. It is the description of how far the tumor has spread from the site of origin or the primary site. Let's review the purpose of staging, which we talked about last semester. Now, understanding the extent of disease assists the physician in determining the most appropriate treatment to cure the disease, decrease the tumor burden, or just relieve symptoms, depending on the case. Staging indicates the patient's prognosis or expected survival. It provides a means of comparing local data with national data, and it also assists in continuing research of cancer. There are general guidelines for all staging systems, and they consist of rules for assigning the stage, including timing rules, to ensure that there is consistency within the data. Stage grouping can only be applied to cancers that are alike in site, histology, or both. Accurate and complete assessment of cancer is necessary before staging. Few cases are unstageable. The unknown stage category should be used only after all efforts to identify the extent of disease have been exhausted, or the site or histology does not meet criteria for staging. It is essential to stage uniformly using the same staging system to compare data or results. So you can't take AJCC T&M stage and compare it to SEER data. You have to take the AJCC stage and compare those cases to each other. SEER stage has to be compared to SEER stage. It is also important to seek further information if staging information is unclear to ensure the quality of data. So we just, if you think that, a physician can answer the question of the extent of disease and it's just not noted in the documentation, then by all means, you should ask them. Summary stage is the most basic way of categorizing how far a cancer has spread from its point of origin, usually in organ. Summary stage uses all information available in the medical record. It is a combination of the most precise clinical and pathological documentation of the extent of disease. It is applicable to every site and or histology combination, including lymphomas and leukemias. So all cases should have a SEER summary stage. The limitations to this staging system is that the categories are quite broad, that there is a wide variety of cases included, and detailed analysis of case with specific characters is sometimes not possible. However, the summary stage categories are broad enough to measure the success of cancer control efforts and other epidemiological efforts. So that's why SEER is so important, because they really use the SEER staging to determine if we are being successful with cancer control efforts and other epidemiologic efforts. So that's why I know compared to AJCC T&M, when we get into it, it's very, very specific, and it uses many different personalized medicine type things, but SEER doesn't. And that's because SEER stage isn't It's more used for outcomes data than it is for treatment itself. And once we talk about AJCCT and end staging, you'll understand that a little bit more. Summary stage is a required data field. Both SEER and MPCR central registries require this information. Summary staging consists of a one-digit hierarchical code for each and every site. You can never have a blank field for this field. We always have to put something in it. The higher the code, the greater the extent of cancer, with the exception of code 8, which is for benign borderline tumors, and 9, which is unknown summary stage. So 1 through 4, 4 being the, or 1 through 4, 1 through 7, 7 being the most extensive stage of SEER summary stage that you can have, or a patient can have. Summary stage 2018 is used for cases diagnosed on or after January 1st, 2018. So if we're in 2018 and we find a case that the patient was really diagnosed in 2017, then we would have to use the SEER summary stage 2000 manual in order to summary stage that case. So it always depends, all the rules, and when we use new manuals or revised manuals, it's always determined by the patient's date of diagnosis. Okay, so for summary stage 2018, it's January 1, 2018. Just like the solid tumor rules and the STOR manual and the grade rules that we'll get to as well. The code structure for summary stage is code 0 is in site 1 is localized only, 2 regional by direct extension only, 3 regional lymph nodes only, 4 regional by both direct extension and lymph node involvement, 7 distant sites or distant nodes are involved, 8 the benign or borderline tumors, which are applicable for chapters the brain, the CNS other, and the intracranial gland chapters only. And then there's 9 that we would use if it's unknown, if unknown extension or metastasis for that patient. So that could be worded as, it's unstaged, unknown, unspecified, anything to that effect. And then also, if a patient case is identified by death certificate only, then a 9 will be assigned for that case as well. And we'll talk more about these specific categories now. So we'll start with the in situ. In situ code is 1. The definition of in situ is the presence of malignant cells within the cell group from which they arose or where they started, but there's no penetration of the basement membrane of the tissue. So there's no stromal invasion. So this cancer is just sitting on top of the tissue, okay? In situ does mean in place, okay? It applies to the epithelial tissue only. The tumor must be microscopically diagnosed in order to visualize the basement membrane, okay? So we can never say that a cancer is in situ by radiology or site. It always has to be reviewed by a pathologist. If the tumor is shown to be microinvasive, the case is considered localized. So even if a tumor with only a little bit of microinvasion or little or slight invasion, that's considered localized then, okay? The tumor is no longer considered in situ when there's any type of invasion. You will see many synonyms for in situ listed for the different primary sites. So just pay attention to that. There are many different synonyms that do mean not invasive or non-invasive, not infiltrative and things like that. So many different things can mean no penetration below the basement membrane. Here's an illustration of what in situ looks like. There's the cancer cell that's in the bluish purplish color, and it's just sitting there. It hasn't it hasn't invaded that basement membrane yet. You should note that in the summary stage manual, the guidelines by stage will list when a summary stage code is not applicable for certain chapters. So in other words, the list means you cannot use this code for that chapter. And there are many chapters listed under the code 0 in Site 2. So there are many sites that there just aren't in situ cancers for those sites. So just be aware of that. And if that happens, it's not like you have to memorize those lists. Just know that when you get to that chapter, if code 0 isn't applicable to that chapter, that site in histology, then code 0 won't be listed. So if it's not there, it's not there for a reason. A localized cancer is a malignancy limited to the organ of origin, or in other words, it has spread no further than the organ in which it started, or tissue, if it's like a soft tissue tumor or something like that. So, but most often it's of the organ, so it has spread no further than that organ in which it started. There is infiltration past the basement membrane of the epithelium into the functioning part of the organ, but there is no spread beyond the boundaries of that organ. A tumor can be widely invasive or even show metastases within the organ itself and still be considered confined to organ of origin or localized in summary stage. For organs that have definite boundaries, such as prostate, testes, or stomach, or sites where there is a clear line between the organ of origin and the surrounding region, such as breast or bladder, it is usually straightforward to determine whether the cancer is localized. An exception is skin, because it is sometimes difficult to determine where the dermis ends and the subcutaneous tissue begins. For most internal organs, it is not possible to determine whether a tumor is localized without exploratory surgery. However, with the increasing sophistication of many imaging techniques, it may be possible now to determine whether a cancer is localized or regional without surgery. And though usually they use an MRI for that type of imaging. Because summary stages uses both clinical and pathologic information, it is important to read the pathology and operative reports for comments on gross evidence of spread, microscopic extension, and metastases, as well as diagnostic imaging reports for mention of distant disease. So we just have to remember that we have to take all the information into account when assigning the summary stage. If any of these reports provides evidence that the cancer has spread beyond the boundaries of the organ of origin, the case is no longer considered localized. On the other hand, if the pathology report, the operative report, and other investigations show no evidence of spread, then the tumor may be assumed to be localized. This is the illustration depicting a localized cancer. The cancer cells are actually invading the basement membrane and extending into the stroma, which is this pinkish color that's kind of hard to see. Once again, there is a list of the chapters, that state when code 1 cannot be used. I think for this chapter, there's only 2 that are listed. For cervical lymph nodes and unknown primaries. I think it's called cervical lymph nodes and unknown primary, or ill-defined other chapters. So those 2 chapters, 1 is not an option for those. Regional stage is perhaps the broadest category as well as the most difficult to properly identify. The brief definition of regional stage is the tumor extension beyond the limits of the organ of origin. Although the boundary between localized and regional tumor extension is usually well defined, the boundary between regional and distant spread is not always clear and can be defined differently by physicians in various specialties. The subcategories of regional stage describe the different methods of regional spread of the tumor. So first is the tumor invasion through the entire wall of organ into surrounding organs and or adjacent tissues, which is code 2, regional by direct extension or contiguous spread beyond the limits of the site of origin. So that's code 2. Next is the tumor invasion of the lymphatic walls where cells can travel through lymphatic vessels to nearby lymph nodes where the cancer cells are filtered out and begin to grow in the lymph nodes. This is code 3, regional by lymph node only. The primary tumor is still confined to the organ, but the cancer cells have traveled to the lymph nodes through the lymphatic walls, and the lymph nodes now have cancer in them. So you can have a tumor that's localized as well as positive lymph nodes. And once again, that's code 3. If there's a combination of direct extension and lymph node involvement, then it would be code 4. Regional by direct extension and regional lymph nodes involved. So basically, if your tumor has both regional by direct extension only, code 2, and is regional lymph nodes involved only, code 3, then you have code 2 plus code 3 equals 4. Okay, so if you have both regional by direct extension and regional lymph nodes involved, you have code 4. So it's just always a fun way for me to remember that 2 plus 3 is really 4 when it comes to summary stage. Just don't teach that math to your children because they will think you're crazy. But when it comes to summary stage, 2 plus 3 equals code 4. Clinicians may use some terms differently than cancer registrars. Therefore, it is important to understand the words used to describe the spread of cancer and how they are used in staging, which we'll talk about in a moment. So this is an illustration that's demonstrating the different ways in which a tumor can travel. You have the capillaries. It can go through the capillaries, it can go into the blood vessels, and so on. So, and once it gets to the blood vessels, then then that's how distant metastases come. So that's, so for stage codes 2, 3, and 4, the manual, once again, does mention when these can't be used as well. But like I said before, these codes, if they aren't applicable to the chapter that you're working in, then they just won't be listed. So your manual is correct. If it's missing something, it's truly supposed to be missing something. So like I said, clinicians may use some terms differently than cancer registrars. So it is very important to understand the words used to describe the spread of cancer and how they are used in staging. For example, local or localized can be stated as something like cancer of the stomach with involvement of the local lymph nodes. Now, local lymph nodes are the first group of nodes to drain the primary site and are often referred to as regional lymph nodes or regional nodes. If a physician states the patient's cancer is localized with positive lymph nodes, that does not mean that we assign stage 1, okay, for localized only. Sometimes physicians state the patient's cancer in this manner because to them, for most sites, this patient could undergo a surgical resection of the primary site as well as the positive lymph nodes, and they could be disease-free. So sometimes, even though the patient may have positive lymph nodes, the physician may refer to it as localized or non-metastatic. Or you could have the opposite, where the physician could say, where metastases is used in the context of carcinoma of lung with peribronchial lymph node metastases, okay? Metastases in this context means it's involved by tumor or cancer. It can be stated that there is metastatic disease in the regional lymph nodes since the cancer has spread to those lymph nodes. However, that does not mean that the patient has distant metastases, okay? So it is very important to understand that terminology can be used in different ways, and we must pay close attention to the information and, within the medical record, all the different documentations, and not just pay attention to what is stated in the summary by a physician. For solid tumors, the terms fixed, matted, and mass in the hilum, mediastinum, the retroperitoneum, or mesentery, with no specific information as to the tissue involved. If these words were used, then you would consider that the lymph nodes are involved, okay? So if the physician does breast exam on a woman and describes the breast mass and then says the axillary lymph nodes are fixed, then you know just by that clinical statement that the lymph nodes have cancer in them. They are positive, okay? So if those different terms are used, that means it is the cancer does involve those lymph nodes. Now, terms such as palpable, enlarged, visible swelling, shoddy, lymphadenopathy, these terms should be ignored if there is no treatment to indicate that there is lymph node involvement, okay? Sometimes, though, the radiologist will use these terms, and then the medical or radiation oncologist may review the imaging with the radiologist to get a more specific determination if these, enlarged, shoddy, or this lymphadenopathy most likely is involved by cancer, all right? And if their conversation, they decide, yeah, this is, most definitely probably the lymph nodes are involved by cancer, and then the patient is treated as if they have positive lymph nodes, then we can consider those lymph nodes as being involved with cancer. Okay, so unfortunately, no, the radiologist will not usually make an addendum to the imaging report, to indicate that conversation or this new, information. But the oncologist will make a statement of the lymph nodes being involved in their note. So that's what it means by terms to be ignored if there is no treatment to indicate lymph node involvement. If, the patient had a stomach tumor and there weren't any lymph nodes involved, and then most likely the patient would have surgery. If the patient, the physician states localized stomach mass and palpable, enlarged lymph nodes, but they're treated with just a surgical resection of the stomach, then, and the nodes were not removed, then you could assume that those lymph nodes were not positive or involved because of the treatment that was given did not indicate that they were positive. Some lymph nodes are accessible, which means they can be seen, palpated, or examined without any instruments, such as the lymph nodes of the breast, oral cavity, and skin, and many more. A statement such as remainder of examination is negative by a physician in the pre-op report or history and physical consult, that is sufficient to determine that the regional lymph nodes are negative. The physician does not have to state, axillary lymph nodes are, normal. They don't have to say axillary lymph nodes are negative. If the axillary lymph nodes are not mentioned for breast cancer for the breast exam, then we can assume that it is negative. All right, the physician does not have to state it for it to happen. However, some regional lymph nodes are not palpable and therefore inaccessible. These are lymph nodes within the body cavity for like the bladder, kidney, prostate. If a patient has surgery and the surgeon does not remove any lymph nodes, the best place to look for information about the lymph nodes is the description of the surgeon's evaluation at the time of their exploratory surgery or their definitive surgery. And that is why it is so important that we read the op report very carefully, all right? When the tumor is localized and standard treatment for a localized site is done, it is sufficient to determine that the regional lymph nodes are negative. Okay, so we're going to use information that's given to us through the op report descriptions or by the type of treatment that the patient receives. Now, how do you know what standard of care treatment is for a specific localized tumor? Remember the NCCN treatment guidelines that we used last semester? That's how you would be able to look at that, see, what the standard of care would be for that type of cancer. And if that's the type of treatment they received, then we can assume for summary stage that the lymph nodes were negative or are negative. An example of this Could be a patient that did not have a primary tumor surgically removed. For instance, a lung tumor for a patient that cannot undergo surgery for some reason. If the patient would receive radiation to that lung tumor only, then we can assume that the lymph nodes are negative, okay? Because if that patient had a lung mass with positive lymph nodes, then the radiation that the patient would have received would have been to the lung tumor and the regional lymph nodes. So we can assume things by the treatment that a patient gets for the summary stage. Now, the isolated tumor cells, or the ITCs, are sometimes counted as positive nodes. Now, the isolated tumor cells are what they are found in the lymph nodes, in the regional lymph nodes. So, and sometimes for certain sites, if there are ITCs in the lymph nodes, they're counted as positive. But sometimes they aren't counted as positive, and even though there are ITCs in that lymph node, they are considered negative lymph nodes. So you just have to read each chapter carefully, and this pertains to breast and melanoma of the skin. Those are the two I can think off the top of my head. So, and the reason why they aren't considered positive for some sites is because the only reason pathologists can see ITCs is because of the types of testing and stains that the pathologists can do now that they couldn't do 15 years ago. So they kind of want to keep that separated out. There's even, for the AJCC staging, there's even different notations and that we make to state whether it was ITC positive or not. Because when we didn't have these staining tests available to us, there are sure people that, 15 years ago that had breast cancer had those ITCs, but we just didn't know it. So we have to make sure that when we compare data for staging like that, that we keep these different things in mind. But so just be careful with the ITCs, and some sites, yes, the nodes would be considered positive, and sometimes they are considered negative. If the chain of lymph nodes is not listed as a regional lymph node in the SEER summary category, first verify that the chain of lymph nodes, or the lymph nodes that were removed, aren't a synonym of a lymph node that's already listed. Okay, so there is an addendum an appendix in the manual that has the different chains of lymph nodes and the synonyms that are also used. So first, if you're looking to see if the lymph nodes that were positive were under the regional lymph nodes and it's not listed, then double check, make sure that it's not a synonym of one of them. And then if it's not, then we can assume that the lymph node that they're stating is positive is a distant lymph node, or lymph nodes which are involved with cancer or positive, okay? Because for distant lymph nodes under the distant SEER summary staging category, they're not going to list every single distant lymph node chain under there. So that's why they say if it's not under the regional list, then we can assume that it is a distant lymph node. So distant metastases is code 7. These are tumor cells that have broken away from the primary tumor, have traveled to other parts of the body, and have begun to grow at a new location or locations. Distant stage is also called remote or diffuse, disseminated, metastatic, or even secondary disease. So many different terms can once again be used. For distant mets, there is not a continuous trail of tumor cells between the primary site and the distant site, okay? So cancer cells can travel from the primary site in any of 4 ways. The first is extension from the primary organ beyond the adjacent tissue into the next organ. Okay, for example, if the patient had a lung tumor that grew through the pleura and into the bone or the nerve, that would be, the extension of the primary beyond that organ and into other organs, which even though it is all one big tumor yet, it would still be considered a distant metastases, okay? That can happen with some colon cancers too in that. So we have to be careful, to pay attention. So like they're saying, there are 4 different ways that, the cancer can travel beyond the organ of origin. The cancer can travel in lymph node channels beyond the first regional drainage area. Tumor cells can be filtered and then trapped and begin to grow in any lymph node throughout the whole body. Okay, so it can be in the regional lymph nodes, but then it can also, if it continues to travel throughout the rest of the lymphatic system, it can start to grow in distant lymph nodes as well. Then there's the hematogenous and or the blood-borne metastases. And this is when the invasion of blood vessels within the primary tumor, the veins are more susceptible to invasion than thicker-walled arteries, but they allow the escape of tumor cells or tumor emboli, which are then transported through the bloodstream to another part of the body where it once again lodges in a capillary or arteriole or artery, and then at that point the tumor penetrates the vessel wall and grows back into the surrounding tissue of that capillary. And I'll have a illustration of that in a minute. And then cancer can also spread through the fluids in the body cavity. An example would be malignant cells that rupture the surface of a primary tumor and then are released into the thoracic or the peritoneal cavity. These tumor cells then float in the fluid and can land on and begin to grow on any tissue that, that fluid reaches. This type of spread is also called implantation or seeding metastases. Some tumors form large quantities of fluid called ascites that can be removed, but the fluid rapidly reaccumulates. However, the presence of fluid or ascites does not automatically indicate dissemination of cancer. All right, there must be cytological evidence of malignant cells in that ascites or the fluid within the cavity, the peritoneal cavity. Also, the hematopoietic, the immunoproliferative, and myeloproliferative neoplasms are distant, except as noted in the summary stage chapters. So by rule of thumb, the leukemias, The blood disorders are almost always considered distant, summary code 7, unless that chapter states differently, okay? But keep in mind that those are the 4 ways that cancer cells can travel from the primary site and become distant metastases. And this is just an illustration of those, different ways. There can be those secondary tumor sites that the tumor cells have gone through a different part of the body and have just stopped and started growing in a different area. And it can go through the lymphatic system, blood vessels, or like I said, through the fluid. Oh, I forgot. That's the blood cell or the blood vessel or lymph vessel, and then that one that's adhering to capillary, and then this one is actually penetrating through the capillary wall where a secondary tumor then begins to grow. So those are just a little bit of illustration of how distant metastases develops. So as stated earlier, for benign and borderline neoplasms that are reportable, we use code 8. However, this is only for brain, CNS other, and intracranial gland neoplasm chapters only. If a cancer registry collects other benign and or borderline tumors or neoplasms that are not reportable, those cases, remember we talked about them last semester, they're called reportable by agreement. Those we would have to use code 9. Even though they are benign, we would have to use code 9. At this time, code 8 will only be allowed for those 3 chapters, the brain, CNS other, and intracranial gland. Last but not least, we have unknown. There are times that you will have to use the unknown summary stage, which is code 9. And there are certain cases in which you must code it as 9 or unknown. There will be cases where sufficient evidence is not available to adequately assign a summary stage, which could include when a patient expires before workup is completed, patient refuses workup, happens many times, when limited workup is performed due to age or comorbidities that would make the patient unable to receive treatment. Sometimes the stage will be unknown. Sometimes someone will be diagnosed with a cancer, but whether they have localized disease or distant disease due to their age or, comorbidities or, life expectancy as it is, they may not do further workup because it doesn't matter what stage that patient is, they would not be able to receive any treatment. So if the patient's not going to receive treatment, then they're not going to spend that money to determine how far that cancer has spread, because it really doesn't matter, unfortunately. So it's just one way in which we can save medical dollars by not doing those additional tests if it's not going to make a difference in how the patient is treated. SEER stage code 9 must be used when the primary, there was one other situation where you might have an unknown stage, and that's when only a biopsy done and the medical record does not provide enough information to assign a summary stage for any number of reasons. Sometimes patients, you just have the information of a biopsy and you don't have any other information, then you would also have to assign that as unknown summary stage code 9. So then for code 9, must also be used when the primary site is unknown, okay, which is topography site code C80.9. So if you're abstracting a case that's an unknown primary and your topography code is C80.9, your SEER summary code has to be a 9. If you don't put a 9, you're going to get an edit. Same for death certificate only cases, okay? Those have to be assigned as a SEER summary stage 9, okay? So there are sometimes you might have to use a 9, and then there are 2 times that you have to use a 9. So let's review some of the general guidelines. And these start on page 21 if you're in your manual. I'm not going to go through all of them, but we'll go through some of the more complex ones. So for each site, summary stage is based on a combined clinical and operative pathologic assessment. So gross observation at surgery are particularly important when all malignant tissue is not removed. Okay, so sometimes the surgeon might say, oh, the tumor is going way into the liver. You know, I'd have to remove the whole liver to get the whole tumor. Therefore, he does the resection but leaves that tumor in the liver. Okay. So we have to use that information that was in the operative report to understand and know the extent of disease, okay? So if there is a discrepancy between the pathology and the operative reports concerning the excised tissue itself, priority is given to the pathology report. But just remember that there are going to be times that the pathologist doesn't have all the information from the surgery. Okay, so if you know there was disease left over and the pathologist doesn't know that, you can use the information from the op report. Summary stage should include all information available through completion of surgery or surgeries in the first course of treatment, or within 4 months of diagnosis in the absence of disease progression, whichever is longer. So if the patient has workup and they have, let's use colon. So the patient's identified to have colon cancer, they have their workup, they end up having a hemicolectomy surgery. That's it. That's the information that we use because they've done the workup and they've had surgery. So that's the information we use. Okay. If for some reason someone's identified with the colon cancer and don't have that, they don't begin that any treatment, then let's say, someone just says, I'm going to postpone any treatment, whether it's surgery or neoadjuvant therapy or anything like that. They want to go on a long trip and they come back 5 months later. That's after 4 months. You won't use any of that information after that, okay? Or once in a while, someone maybe could have colon cancer or rectal cancer. And they decide they're going to do chemo, radiation therapy before surgery. But as that patient is getting the chemotherapy and radiation therapy, they end up having getting metastatic disease to their liver. The cancer progressed. Then we have to use just the information before that patient progressed to assign the SEER summary stage, okay? And as you do, assignments and things like that, this will become more clear. And it's really, it's a rule that's there, and it sounds more complicated than it really is. So just remember it's there and don't worry about it for now. Right now, we don't have any cases that you'll even have to pay attention to that. So chapter-specific guidelines take precedence over general guidelines. Always read the information pertaining to that chapter that you're using before reviewing the general guidelines. When multiple tumors are reported as a single primary, basically a single abstract is being completed, assign the greatest summary stage to any, from any of those multiple tumors, okay? So if one tumor is more extensive than another tumor, then that's what you're gonna assign as your SEER summary stage. Information from the surgical resection after a patient has received neoadjuvant therapy may be used, but only if the extent of disease is greater than the pre-treatment clinical findings are, okay? So if they have a clinical stage of regional by direct extension only, lymph nodes look negative, so we're assigning a summary stage code 2, all right? The patient goes on to have neoadjuvant therapy, so we don't have to, we can wait till they have surgery before we do a final, assign a final summary stage. So they go through their neoadjuvant therapy. The patient has a surgical resection, and upon that surgical resection, they find that the patient has multiple lymph nodes that were positive for cancer. Then we are going to assign the SEER summary stage as a 4 because the patient had direct extension of the primary tumor and positive lymph nodes noted surgically, even though it was after neoadjuvant therapy. It doesn't matter because it was worse than what it was expected or thought to be. So then it would be SEER code or summary stage 4, okay? But if the physicians say it's the patient has direct extension and lymph nodes positive, they have chemotherapy and radiation therapy, but then on surgical resection, the lymph nodes are negative, we're not going to use that surgical information because clinically that patient had positive lymph nodes. And the chemo and radiation did what it was supposed to do. It killed the cancer in those lymph nodes, and now they're negative, okay? So we have to use the information before the neoadjuvant therapy was given, okay? So you only use the surgical resection information after neoadjuvant therapy if the stage is greater than what it was before treatment. You need to exclude any metastasis known to have developed after the diagnosis was established, okay? So, the diagnosis is done, the workup is done, and then for whatever reason, suddenly they have a progression before, treatment was started or whatever. We can only assign the summary stage using the information up to the point where that patient's cancer progressed or got worse. Autopsy reports are used in assigning summary stage exactly like any other pathology reports are. They apply the same rules for inclusions and exclusions. It doesn't matter that it's a autopsy pathology report. It's still, you use it in the same way as any other pathology report. The summary stage may be described only in terms of tumor, the T, N node and M metastasis characteristics. In such case, record the summary stage code that corresponds to the TNM information. Once in a while, and hopefully this won't happen very often, but let's say the patient had all their workup and their surgery at a different facility and comes to your facility for radiation therapy or just chemotherapy, and you don't have access to any of that previous information. All you have is the oncologist staging it, using T, N, and M. Well, you can use their T, N, and M information to assign the SEER summary stage if that's, all you have. That's fine. However, if there is a discrepancy between documentation in the medical record and the physician's T&M staging, let's say you have that documentation and the physician did a T&M staging, the documentation takes precedence, okay? No one's perfect, everyone makes mistakes. So, if you know by the pathology report that the cancer is, one stage and the physician has it incorrect, use the documentation, okay? Don't go by what the physician, documented, all right? Like I said, no one's perfect. We all make mistakes. So just, physicians aren't God, their say isn't the last say. So just know that, use the information that you should. If you think, though, that the documentation in the medical record is not complete, then assign the summary stage to correspond with the physician's T&M stage. Let's say you didn't have all the documentation necessary to determine if the physician is right or not, then just go by what the physician, how the physician staged it using the T&M. And once again, death certificate only cases and unknown primaries have to be coded 9 or summary stage unknown. For efficient assignment of the summary stage code, here are some additional guidelines, okay? So these are, if you look at your case in the way that these additional guidelines are, it will help you determine more easily what summary stage the patient has. You can quickly rule out in situ, distant, and localized, okay? So that's basically what you're gonna do right away, okay? So you can easily rule out in situ stage disease, okay? So remember, carcinomas and melanomas are the only types of cancers that can be classified as in situ, okay? Only carcinomas have a basement membrane, and sarcomas are never described as in situ. So any chapter like the sarcomas and other chapters that have that the histology is anything but carcinoma, they're not even going to have that in situ summary stage code 0 there in the book for you to choose from, okay? So if a patient has invasive or infiltrating whatever type of cancer, the patient doesn't have in situ. So it's like, yep, easy. Patient doesn't have in situ, okay? And remember that pathologists must examine the primary organ and state that a tumor is in situ. Remember, in situ cannot be seen by the naked eye, okay? You can only see it through a microscope, all right? And once again, if the cancer is anything except a carcinoma or a melanoma, it cannot be in situ. If there is any evidence of invasion, like I said, or extension to nodal involvement or metastatic spread, the case is no longer in situ. It can't be in situ, okay? So just, remember, the minute you see metastatic or positive lymph nodes or invasion, nope, not in situ. All right. And then evidence of invasion or extension to nodes or metastatic sites cannot be in situ, even if the pathology report states that. Let's say a patient has a mastectomy and all the pathologist can find within that breast tissue is in situ carcinoma. However, the patient has at least one positive axillary lymph node, okay? Well, an in situ cancer cannot metastasize or travel to the lymph nodes unless it was invasive, okay? So sometimes, even with melanomas, the invasive component of a cancer can, regress or disappear. So if a pathologist states, all the tissue that was reviewed and looked at, all of it was in situ, but there was positive lymph nodes, it's no longer, you no longer can assign summary stage code 0, okay? Because once again, in situ cancer cannot travel to any other part of the body. And then the next thing is to rule out distant disease, okay? So if metastases is documented, there is no need to, spend a great deal of time identifying whether the patient's cancer is local or regional spread, okay? If the distant metastases is recorded, by the X-ray or by a needle biopsy, the stage has been determined, okay? So you just go ahead and assign summary stage code 7. All other information no longer matters when it comes to the summary staging, okay? So if a patient has colon cancer and it was proven that there were multiple metastatic liver lesions, okay, patient liver lesions, distant metastases, summary stage 7. Okay, unfortunately, people with stage 4 cancer are those that are easiest to sear summary stage. So makes it easy for us, but it's kind of depressing for them. So, but just know that the second you know there's distant metastases, you don't have to use any other information to determine what you're going to assign the summary stage code as. Now, hematopoietic diseases such as leukemia and multiple myeloma are considered disseminated or distant at the time of disease. So anytime you have a leukemia or a multiple myeloma, it's 7. It is what it is. That's what has to be assigned, okay? So those are also easy cases to assign the summary stage to. Rule out distance spread by reading the operative report for comments about seeding, implants, liver nodules, or other indications of metastases, okay? Read the diagnostic reports for references to distant metastases or distant disease. A lot of times reports will say no other distant disease identified or something like that, but they're not always going to say that there's nothing else there, okay? So if the radiologist doesn't state that there's something distant or, metastatic, we can assume that it is that the patient does not have metastatic disease. If nodes, organs, or adjacent tissues are not specifically mentioned in the description of the various categories, attempt to cross-reference the term you have with those outlined, okay? There is no match. Assume the site in question does represent the distant disease. Okay, like I said, not every distant site is going to be listed under distant for every site. The book would be more than twice as big as it is now. So once again, it's pretty easy to assign to either determine that the patient does or does not have distant metastases. Then the additional guidelines for localized disease, you want to rule out that the cancer is confined to the organ of origin. So in order for a lesion to be classified as localized, remember, it must not extend beyond the outer limits of the organ, and there must be no evidence of metastases anywhere else, okay? Terms such as blood vessel invasion or perineural lymphatic invasion do not necessarily indicate that the cancer has spread beyond the primary organ, okay? If tumor at the primary site has invaded the lymph or blood vessels, there is the potential for malignant cells to be transported through the throughout the body, but until that is proven, just that invasion within the organ itself is not anything beyond localized. Minor vessels or vascular invasion within the primary site is not a determining factor in changing the summary stage unless there is, once again, definitive evidence of tumor at a distant site. Okay, so just pay close attention to those terms and knowing that that does not mean that the tumor has gone beyond the organ of origin, because remember, every organ also has blood vessels and lymphatic system going through it. So if it's still within that organ, then it's still localized. If in situ, local, and distant categories have been ruled out, the stage is obviously regional. For tissues, structures, and lymph nodes, assume ipsilateral unless stated to be contralateral or bilateral. So if for lung, if the radiologist stated the patient has a left lung mass with metastatic disease to the hilar lymph nodes, and they didn't say whether they were the left or the right hilar lymph nodes, we would assume that it was the same side as that tumor, or ipsilateral. Okay, so keep that in mind. For solid tumors, if there are lymph nodes involved with the tumor, the stage is at least regional. Okay, so keep that in mind. All right, so and then for regional stage, you need to determine then whether it is regional by direct extension or regional lymph nodes or both. Okay, remember that you can have a tumor confined within that organ of origin with positive lymph nodes. Okay, that would be your regional lymph node involvement. Okay, if you had a tumor that grew beyond the organ, but lymph nodes are negative, then you have regional by direct extension only. And if you have both, then you have regional, direct extension, and lymph node involvement, and would be that summary stage code 4. Once again, unknown if extension or metastases is there. If there is not enough information in the record to categorize a case and contacting a physician is not possible, or you have and it has resulted in no additional information, then the case must be recorded as unstageable or unknown Sears stage code 9. Now, how do you begin to assign the summary stage? Keep the process in place in your mind, how they said, first determine if it is in situ. Is it distant mets? Okay, because those are very easy to determine. Okay, so kind of go through that process that those went through. And basically, to assign the stage, you're asking yourself these 4 basic questions, okay? Where did the cancer start? In what organ or tissue did the tumor originate? Is there a specific subsite of that organ involved? Information about the primary site will usually come from the physical examination, diagnostic imaging report or reports, the operative report, and the pathology report. Code the primary site according to the rules in the ICD-10 manual, the solid tumor rules, or the hematopoietic manual, depending on the type of cancer you have. In addition to recording this code in the primary site field on the cancer abstract, this code will be useful later in the staging process, okay? So keep that in mind. The second question, where did the cancer go? Once the primary site is known, determine what other organs or structures are involved. Review the physical examination, the diagnostic imaging reports, operative reports, pathology reports, laboratory tests to identify any structures that are involved by cancer cells. Any of these reports can provide a piece of information that might change the stage. Okay, so that's why we have to read all the reports that are available. Note whether there is lymphatic or vascular invasion and or spread, which organs are involved, whether there is a single focus or multiple foci of tumor. It is important to know the names of the substructures within the primary site, as well as the names of the surrounding organs and structures. Hence, the requirement of so much anatomy and physiology for this profession, okay? Make sure you note the names of any tissues that are reported to be involved by cancer cells within your text. The next question, how did the cancer get to the other organ or structure? Did the cancer spread to the new site in a continuous line of tumor cells from the primary site? If the pathologist can identify a trail of tumor site cells from one organ to another, the stage may be regional by direct extension, or it may be distant by direct extension. Remember that example I gave you before, the patient's lung mass grew outside of the lung, the pleura, and into the bone? That would be distant metastases, even though it is by contiguous growth of the tumor. Did the cancer spread by breaking away from the primary cancer and float to a new site in the bloodstream or the body fluid? There is no direct trail of tumor cells from the primary organ to another site. The stage is probably distant, all right? Only a few, I can think of one off the top of my head that would not be considered distant, so just pay close attention to that. And remember how the different ways of spread of cancer, helps us determine the type of Sears summary it is. Last question that we would ask ourselves, what are the stage and correct code for this cancer? So when you open the summary staging manual to the chapter that includes the site and histology code that you identified your case to have, Okay, so you want to make sure that you review the chapter, you know, and that chapter has that histology listed and the topography code listed, and we'll review that next week. But then when you go through the chapter, you know, you want to review the structures and the organs that are reported to be involved. You want to look for those in the listing in the chapter, all right, because that's how you're going to determine the extent of disease. Where is that tissue or organ listed? And then that's where whatever code that is listed under, that's the stage we assign. If more than one structure or organ is involved, then we want to select the highest category that includes an involved structure. All right, so we always take the most extensive code that the tumor involves. Make sure you are familiar with the definitions of the terms used in this manual on pages 26 and 27. All right, these terms are very important when it comes to summary stage. There are two lists for interpreting ambiguous terminology for summary stage on page 29. One is a list of terms that should be considered as involved, and the other list is terms that mean that the tumor is not, or that tissue is not involved by the cancer. All right. Use this list, use both of these lists as a guide only when there is no other information available. Okay. If you have to use the involved list, pay attention to what the asterisks stand for as well, okay, because those are very important, all right? Just remember that, you know, we're only going to use these ambiguous terminology lists if we have nothing else to go by, all right? After the ambiguous terminology list on page 29, there is a table that indicates the summary stage site-specific chapter, and then it lists its corresponding EOD schema. EOD is also a staging system, and we're not going to learn that in class. Right now, not many registries are collecting that information, and you're not tested on it for the CTR exam, so we won't spend time working on that. But this table shows, you know, the summary stage site-specific chapter. It lists the corresponding EOD schema. Then it tells you the AJCC chapter number that correlates with that summary stage chapter. It gives the number of the chapter as well as the name of that chapter. So the table starts on 30 and goes through 34. And it's not like you have to use it, but it's just a way that you can make sure that you're using the right chapters for each of the manuals. So it's something that they added to this edition, which I think will be very helpful to just have, you know, make people more aware, to double check and make sure that they are using the correct chapters in the different manuals. Or if you look at that table, you can just go directly to that chapter in your other book, and you don't have to look it up using the index and things like that. So it's just like a second check thing to use. Then there is a section with the definition of anatomic sites within the head and neck. We will not work on head and neck cases this semester, but this is a very important part of the manual. When you do start abstracting head and neck cases, So this is very important information. Head and necks are very difficult cases to do just because there are so many structures and they're so small and things like that. So that information will definitely help you understand assigning, staging, as well as understanding those sites themselves. After that section, the summary stage chapters begin with the cervical lymph nodes and unknown primary tumors of head and neck. Now, sometimes it will be proven that a patient has a primary cancer of the head and neck due to positive lymph nodes. However, when the patient undergoes a workup, the primary site cannot be found, okay? If we are abstracting a case like that, we would use this chapter, okay? But just how a melanoma can regress, head and neck cancers seem to do the same, or they're so tiny that no scan can pick it up, whether it's a CT scan, a PET scan, you know, all those structures are negative, but you have these positive lymph nodes. But by the histology or cytology of those lymph nodes, it's proven to be a head and neck primary. We would use this chapter to assign the correct SEER summary stage. And when you start to page through the manual, you will see that there are many site-specific chapters for the head and neck, since there are so many different primary sites within the head and neck. So, you will definitely, you know, want to tab, you know, for sure tab the sites that we're going to be working on this semester. If I don't have them listed for this week's reading, it is listed for next week's. So those are the ones that we're going to be really focusing on this semester. So, and you can use the little plastic tabs, or you can put dividers in. Dividers, you know, might be too bulky for this manual, because some of the chapters are only a few pages, you know, but maybe you could put a divider in for like the digestive system and urinary system and things like that, and then put plastic tabs for the different sites or the smaller chapters themselves. So that concludes the overview of Summary Stage 2018. Now next week, my presentation will go over how each chapter is formatted and the specific steps that you need to take in assigning the summary stage for the different sites. So we will, next week, the presentation will be viewing the manual itself and going through cases. Your reading assignment this week is to read pages 9 through 29 of the manual. Your assignment this week will cover this presentation and those pages, just 9 through 29 in the manual. That's all the answers will be found either in the presentation or on pages 9 through 29. Next week, we will begin to assign the SEER summary stage to case studies, okay? So I'll go through cases in my presentation, and then as well, you know, then you'll do it as your assignment as well. As always, please post any questions or comments in the discussion or my virtual office, okay? So everyone have a great week.